want to give a special shout out to Live Illustration, who've been with us through the journey on almost every one of our briefings. Many people tell me that they really, really love the illustrations, and on my own view is that they've really added to the value of these moments. So as well as having you as a community, we have the illustrations, we have videos, we have a WhatsApp group, and we have a number of initiatives that have sort of been, I think, sort of supported through this. And it's great that Claire Rayner is on again. I was listening, Claire Rayner, to some remarks from Janet Diaz at WHO, and just understanding how very focused they have become on the way in which COVID can stick around and cause long-term symptoms. And she was saying there's been a group of really great people who are affected by long COVID who've been connecting with us, and they've had a big impact on us. I wasn't sure whether Claire Rayner was in her mind, but I know, Claire, that you have been very active with others, of course, with Robin Gorner, who was how we first connected with you, in just trying to make sure that people in positions of authority understand that long COVID has to be taken seriously. It is of huge social and economic and human significance. And I like to feel that it was through letting that feeling emerge in our group that we contributed to the energy that has got long COVID on the map. Of course, in the kind of systems leadership that we try to do, you can never attribute a result to a particular input. Unlike when you do linear work, when there's a lot of effort to prove that your input led to your result, and you get very frustrated if you can't make that proof stick through bits of econometrics or other similar analysis. When you do systems leadership, the one key feature about it is that it's almost impossible to attribute an outcome to the input of an individual. You can develop hypotheses, but you can't say, yep, we did that. You have to say, we contributed to it. And I think as a group, we've contributed to many things over the 85 OOBs so far. I think we've focused on the disease and the epidemiology in a pretty, I think, careful way. We've focused on the disease and particularly long COVID. We've focused on diagnostics, treatments and vaccines, and particularly equitable access. And we focused more generally on the fundamental inequities associated with this issue alongside other health inequities. But we've said it's not just a health issue, it touches so many other aspects of human well-being, particularly loss of employment, and that loss of employment really hits folk on low incomes, and we're hearing about that more and more. So that's just my feeling as to what we've been able to do in terms of our work. I would like to say that I think we've also been able to really focus on why systems leadership matters in dealing with an issue like this. You cannot deal with it through linear interventions. You have to deal with it through have a palette of interventions that you offer to try to shift systems to a better place. And isn't it wonderful that we've also on this journey been able to link with Vicky and Nazeem, and we've been able through that creative partnership to be witness to Nazeem's ability to take some of the ideas that we share, link them to his own feelings, also Vicky's inputs of what she's seeing and the communities that Nazeem and Vicky work with, that have enabled us to then watch some of our ideas being reflected in his words in Nazeem's lyrics. And I suppose for me, that translation so that it's appeared in music and beautiful music has been very, very important to me. It's also been important that we've had Derek's videos, and also important that several of you have taken ideas from these online briefings and incorporated them into creative work. Like I like to believe some of the work with creative actors that Scott Knox has been doing in Canada. I don't know whether Scott would say that's happened, but I like to feel there's a bit of fertilization. several of you who've got jobs working for governments or working in institutions, working in health services. So that means that you are contributing to policy and practice where you're working. And I like to think that the aspects of what we discuss here are useful to you. And in turn, we benefit from your findings when you come in to us. So this is something that we love, and you've heard from Twee, we want to keep it going. We will change the format, but that's only because we have some very, very big challenges on time at the moment. I want to give a big shout out to Catherine Deland, our health systems advisor, who is all constantly here. We've just been spending more than an hour with the other special envoys that WHO has on the pandemic. Tedros was there as well. We've just had another conversation into WHO this afternoon because there's some very, very tough issues. Thank you, Catherine, for all you do. Okay, Paul Thomas, nice to see you. And good of you to join. And periodically, because as I see you, I will shout out. I'm looking to see whether NK SETI is on. Looking across, can't see. Lewis Thomas, good to see you as well. Sarah Phillips, Loy, Rago, excellent too. Those of you who I can't see in pictures, just know that if you do move around and want to get our attention, best way to do it is to put it in the chat. The pandemic is worse than ever. It is really, really bad, the global situation. There's no other words to describe it. What we heard today from the special envoys, 5 out of 6 were present. 1 had to go off to an urgent meeting with her president on COVID issues and couldn't join, but the other 5 were all there. One word, fear. We are afraid. These are experienced, senior public health professionals who've seen a lot and done a lot over a combined probably about 160 plus years of professional experience. They are scared. And the reason why everybody is scared is that we're now being able to see right firsthand, live, the ferocity of this virus and what it is able to do. The situation, not just in India, but in India, Nepal, Bangladesh, parts of Pakistan, Sri Lanka, Indonesia, Papua New Guinea, Maldives, to a degree Thailand, Cambodia, parts of Vietnam. It's not good. The numbers of cases are increasing sharply. Death rates are higher than they were last time round. Hospitals have got younger people in as patients. The majority of people who are dying have got comorbidities. There is between 5% and 10% of long COVID. The numbers of cases, 5 million a week. Do you know it took 4 months to reach 5 million cases reported to WHO at the beginning? Now it's 5 million in a week, and that's reported cases. And we're dealing here with very, very large numbers, an awful lot of the virus around in our world today. You could say, well, it's not a problem. There is vaccination going on. There's 1 billion doses that have been administered across 172 countries, 19 million doses a day. Surely, won't take long, the world will be vaccinated, the problem will be solved. And that's one narrative. But all the analyses suggest that at current rate, the world as a whole will not be vaccinated till late 2022. So what can be done? Can it all be speeded up? Well, that will be one of the things that I'll come to towards the end. But for now, I just want to tell you But the pandemic is worse than ever, and the prospect of it being controlled through vaccination is still at least a year away, and more likely 2 years away. And there'll be a lot of people who are going to get sick with COVID, with long COVID. A lot of people are going to die, and a lot of people whose lives are going to be completely messed up as a result of COVID between now and the end of 2022. And that is a real global emergency. The virus is mutating. Obviously, you get variants that are not so transmissible, and so they will fade away. And you get variants that are more transmissible, and they will become dominant. You get variants that are associated with different patterns of disease. Still not quite sure how many of them there are. And there is an absolute inevitability that variants capable of evading the protection offered by the vaccine will emerge. I asked the chair of the board of one of the manufacturers earlier this week. I said, what is the prospect of developing a vaccine that's capable of dealing with all the potential variants of COVID? And he said, actually, when you look at the structure of this virus, theoretically, the number of mutations that could possibly occur is of the order of 10 to the power of 25, i.e. an incredibly large number of variants is possible from this virus. So right now, with currently available technologies, the development of a single all-conquering coronavirus vaccine is very unlikely. So what's happening now is that same company is using artificial intelligence to try to work out which kinds of variants are likely to have the greatest significance in terms of either escaping the capacity of a vaccine to neutralize or increasing the severity of disease. And using artificial intelligence, I think they'll narrow down the number of possibilities quite substantively, but still we can't get away from the reality. This virus is capable of mutating into lots of different patterns, and it's impossible at this stage to predict what their impact on the body will be using currently available knowledge. And so we therefore have to accept that for the time being, the way in which the vaccine manufacturers will keep up to date with the emerging variants is by having good quality genome sequencing of the viruses and then going into the labs and making vaccines that can deal with the variants that are of greatest concern. So we will always be catch up for now. It won't be getting ahead of the virus. So just please put the word around. The pandemic is by no means over. Number two, let's just keep thinking about the purpose that we need to be working on when approaching this pandemic. For me, it's going to be a world in which the levels of suffering are kept as low as possible. A world. I'm going to continue having a world focus for this pandemic. And I'm going to go on asking all world leaders to have a world focus and to stop viewing the pandemic from either a subnational or a national or even a regional perspective, but to look at it from a world perspective. That means also focusing on equity, because if you look at the pandemic in the world, you see straight away that poor people in poor countries are suffering the most. And so our slogan, which we've said before, we're still holding it, but we'll shift it if you can come up with something better, is fast, forward, fairly. Fairly because we have got to have fairness in there to deal with inequities. Forward because we're moving forward to a new world, a world where humanity lives with this virus and adapts to this virus. And then fast because the one thing that I want to get everybody to focus on is the need for speed. Just going slow about this, waiting for the normal pace of diplomatic negotiations It's just going to be associated with more situations like we're currently seeing in India. India is not the last of these big explosive outbreaks. We had Brazil, India now, but there'll be more to come. Anywhere that's got a fair amount of virus already in the country, with numbers that are being got low through restrictions on movement, when the movements build up again, will be a candidate for explosive outbreaks. That's just the nature of the kinetics of this virus. So the purpose has to be moving fast forward fairly. I want to stress that the third P that we always use is people. I'm continuing to make the point everywhere, and I'm trying to make it more often than ever right now. Virus is the problem, people are the solution. That's because I want to continue to ask leaders everywhere to make the narrative when they're talking to people one of, we're in it this together, we're partners in the response, it's all of us, not just some of us, and what any one of us does has implications for the well-being of everyone in our societies. So we keep coming back to the importance of people functioning individually, people functioning collectively, and doing it in partnership with others, with their employers, with their governments, with their local authorities, with their health practitioners. So I want to keep this people are the solution line up really strong. I'd like all of you to keep saying that as well. The next P in our series is public health. And perhaps what we're seeing right now, particularly with the variants coming on board, is that you really got to, once again, go back to your public health capability if you're trying to deal with emerging variants. It's a case of being alert, then detecting, then responding. And in the response, it's about isolating people with the disease before they've been tested, tracing their contacts, isolating their contacts, having a really good and well-integrated testing process. It's about shielding those who are most vulnerable, if possible, with vaccines, if not with physical shielding. It's about trying to improve ventilation, particularly in indoor spaces. But that public health basis for our response is absolutely essential. And we're going to have to fight to get the focus on public health to be sustained, particularly now with people taking their minds away from the pandemic, because without good quality public health capacities in place, we're not going to be able to deal with it. And then lastly, I've been saying that I am calling for a global response program. And I want to give you a little bit more about what I think that global response program needs to do. First, it's got to be able to do really good epidemiology of what's going on around the world in relation to COVID. You see, if we don't have a really alert and live epidemiological service providing snapshots of what is happening around the world, we run the risk of just making our judgments on the basis of what we are seeing in our local communities. And so I'm very, very keen to ask everybody to think in terms of a program that provides up-to-date information on the epidemiology, as well as variants and their distributions. Then I would like that program to be also supporting countries with immunization. I'd like that program to be assisting on guidance and then the non-pharmaceutical interventions. I'd like to have an incredibly strong communications arm, but most importantly, I want it to be ready to respond in a very supportive and I believe in a manner of solidarity to the situations at country level. You know, we just go to Buenos Aires now, just a few days ago. Test positivity rate 50%. Severe cases spiking. hospitals in Buenos Aires and in other urban areas, forced to turn patients away because they're running out of beds and oxygen. Weekly death rate increased by 21% last week. And the very high test positivity rate is really alarming the government. It's a political crisis in Argentina. We go to Syria. Some of you may know that that country, despite the fact that it's got a humanitarian crisis, it's also got a COVID situation. And the situation and the overload of health services is dramatic. Turkey has just gone into a 3-week lockdown. It's an effort to try to interrupt the high transmission rates. It's particularly high in Istanbul. It's very, very, very disturbing to the population. They've got the 4th highest number of global new daily cases and in new cases per 100,000 population in the last week. Turkey is one of the epicenters. And Turkey is a crossroads country. People go everywhere from Turkey. They come from everywhere to Turkey. And although they've managed to start a vaccine rollout, and they've got 16% of the country has had 1 dose, in fact, of either Sinovac or Pfizer-BioNTech, the situation is extremely serious. We go to Ecuador. Ecuador has got children and young adults now with doubling in incidence of cases, children under 19 years of age in particular, increases in weekly cases and deaths, going up by 10% of cases and 41% of deaths in the last week. They've got quite a lot of cases in children. 1% of the confirmed cases in children have been associated with death. That's a high rate. And generally in Ecuador, the situation is really, really serious. And we've talked about India. Clearly the situation in India is extremely dramatic. And I think it's probably just worth saying that I don't think we're at the end of the India story. I think that there is more coming, and that also needs to be taken into account. So I want a program that will do the epidemiology, do the variants, do the vaccine work and everything else. I don't know whether there is the appetite for that yet, because there's nervousness about creating global actions these days. There's such a lot of skittishness about the UN system. So I thought, well, perhaps we need to think of words that are less worrying to people. Perhaps program is too much implying central control and will not go down well. So I thought I'd invite all of you to think what might a global effort on COVID. If you don't call it a co-program, what you might call it? And then perhaps can we envisage, if there won't be a global program because countries don't yet want to do that, can we at least encourage the linking together of national efforts so that we create cross-border activities, like what we did in bird flu, for example, in East Asia in 2005, where we looked for synergy amongst countries in the Mekong region? Could we go look for coming together of responses to COVID in particular geographical regions? So in order to think about softer language, I thought, does coalition sound better than program? Especially as my view of the program is that it involves government people, but it also involves manufacturers of vaccines. It also involves businesses that want to be involved in the activities. It involves professional organizations of nurses and medics and others. It involves trade unions. It involves civil society groups. It involves broadcasters. For me, a coalition of actors coming together is explicitly designed to bring lots of different stakeholders together, and the power comes from the diversity of people who are involved in that coalition. So I've just been toying with this because I'm sensing that there is just real nervousness about something called a global program. So that's my sort of quick briefing notes for you. Pandemic, ferocious and very disturbing, overwhelming aspects of the health systems in the countries where it's active. And it's happening in multiple locations at this time, in the Americas, in the Middle East, in Africa, in Asia, as well as in Europe. It's not so profound in most of Africa in the moment, but there are areas in Africa, quite isolated areas, where the incidence is very high. And so we really must not assume that any part of the world is let off. And so that brings me to the UK and pandemic from the UK perspective. I'm absolutely certain that there's going to be a resurgence of cases in the UK following the liberalisation of movement, probably in about 3-4 weeks' time. The question is, will it be an explosive resurgence all over the country? Will it be very localised? And what will the actual form be? Will it be, once again, older people, or will it be younger people? Well, I think in the UK, older people are shielded because they're quite widely vaccinated. So as long as whatever virus is causing the disease in Britain is susceptible to antibodies produced by the vaccines, then the UK should not get a big return of high death rates among older people. But there'll be an upsurge, and it'll affect younger people, and it will cause quite a lot of anxiety. So what I'm saying is, to the UK and to all other nations, including the United States, use this time with lower numbers very well. Give hard-pressed people a bit of time off, especially those who've been working like crazy in the health service, but make sure that everybody who possibly can is involved in multi-stakeholder efforts to plan for what to do in case the thing continues to, in case the thing, or when the thing resurges. And that's where the work of the district public health officers in the UK is so important. The effort to try to localise the capacity for detection and response is critical, and the attention to the conditions under which you ask people to isolate is possibly one of the most important variables that you've got to take on board, given all the information we have in the UK, that one of the main reasons why people found it hard to isolate and also hard to respond to the questions from the contact tracers was quite simply that the reward for isolation was insufficient to compensate for the income earnings that were lost. And that meant that there has been, and still is, an incentive for people in the UK and in other places where isolation pay is relatively low. There's an incentive on people not to isolate and not to cooperate with the contact tracers. And that's understood. And so that sort of lesson needs to be taken on board in the UK, as well as everywhere else, because if we expect there's going to be a resurgence, we're worried that it might be a nasty variant that can dodge around the protection offered by some of these vaccines. We also expect that younger people are going to be much worse affected. So let's please use the time now to get ready, and not simply just to be celebrating and saying, haha, job done, because job is not done. So Twee, that was my opening remarks, and I'd now like to have some conversation. I'm very grateful to the 47 people who are on. I'd like to go to Josh, if it's all right, Twee, and if you could highlight Josh's picture so that we can just see what Josh has offered us.
Here we are.
So, thank you. Thank you for picking up the words. Did you want to say anything, Josh?
Not at this time. I'm just going to try and capture this idea of use your time, or use the time wisely for people who are ahead of the virus, and show that people who are not ahead of it, and show that contrast. I'm going to try and get that around this clock face that I'm drawing now.
Brilliant.
Yeah.
One of the things that we've been saying, Josh, a part of that public health, is that it only works if it's really a honeycomb network through society of people who are sufficiently close to their communities that they can actually help them when they are experiencing illness, and they can also help them if they need support. And one of the people on this call has been involved in a lot of work to try to create in the UK a real community-based public health service. And I'm hoping that that person, who's currently not in front of his camera, so I will call on him when he returns, I'm hoping that he might be able to just tell us how that is going. It's a bit of a privilege that he's joined us. Now, several other people are here who are really involved. Just to say hello to Edie Lush. Edie Lush works for Global Goals Cast, which is a group that is really involved in sharing material far and wide on sustainable development issues. And Edie and her colleague Mike Oreskes contacted me the other day saying that they really like these open online briefings. They've been listening to some of them. So Edie, thank you for being here. I'm not going to embarrass you by asking you to speak, but I just wanted to give a bit of a puff for Global Goals Cast and the work that you're doing. And I hope that you can pick up on these briefings if the format works and make them more widely available. Or if you decide that we've got to change the format, please let us know and we'd be very happy to do so. Okay, now, let me just ask Catherine to just come in now and tell me what you've been reflecting on, what you've seen in the people who want to chat, and give me guidance on who you would like me to call on. I'm also asking anybody who's got something to say about what's happening in a country. It's what I'm really interested in, stories from where you are. Please don't hesitate to let me know. So, Catherine, you have the floor.
Sure. Well, what I always like these because I spend less time reflecting and more time listening and reading, which is a treat for me. So, and I think out of the chats, speaking of people reflecting on what's happening in a country, Assad says he's been talking to doctors in India and they are reflecting similar sorts of stories. And it sounds like he has some interesting points. And I might want to mention that Claire has talked about the physical damage that this is causing. And so those two comments, I think, definitely caught my eye. I think there's definitely a sense in the world that is, reflected by Lewis Thomas that vaccine hoarding is really complicated. It's hard not to feel safer knowing that there's plenty of vaccine, but it's in your country, but it's terrible because it's so needed elsewhere. And so I think it creates a really complicated set of emotions and responses when it comes up. So those three are the ones that I noticed right away, but I also wanted to mention that Youssef has some interesting information on the variants and vaccines and cases in Israel. And that there's a couple of good questions on variants in general. Karen Kaplan has one.
Right. So just everybody, Lewis Thomas, you're there. I can see you. There was in your quite long comment on the chat. You said it seems to me that the pitfall in our global response has been and continues to be the lack of shared global humanity. What will it take to make people who see each other as primarily fellow humans in need rather than solely citizens of a nation? Lewis, just a couple of minutes, keep it tight on a little bit more on that, because this is what I am currently focused on more than ever. What could we do to elevate the just core message that you just put in your excellent text insert?
Thanks, David. And I suppose I don't really have an answer to that question, which is partly why I posed it to the group. But I think how I'm feeling is reflected in lots of people in the UK at the moment. I'm involved quite a lot in the vaccination programme, and it's so great when we know that more vaccine is coming and it's been secured for the future. But at the same time, then seeing the images of some of the awful situations that people know around the world, it feels so unjust and unfair that we are somehow benefiting and being privileged just because of where we live. And I think quite a lot of what we've spoken about is how we create this sense of community and collaboration amongst sort of world leaders and decision makers in countries across the world who are working on this. But I think there's something as well about how you create that momentum and mobility within communities too, and how we get everyday and normal people to sort of, I think lots of people feel this conflict and sense of complexity, and how we help them to work through that in a way that makes them appreciate our shared global humanity and makes these world leaders feel somewhat pressured, or at least notice that quite a lot of their own people want vaccine equity globally to be as important as having vaccines for their own country, and really raising that an agenda at a national and grassroots level.
Right, done. Beautiful. And we will work with the campaigning groups on this. Christian Aid's got a big campaign going. Bono and One have got a campaign going, but we need 1,000 campaigns to really get a dent. And I think, Lewis, that is very inspiring. Certainly, you're helping me, and I am not going to rest on this one. Thank you, Lewis. I'd like to invite Asad Khan, actually. I've lost where you are. Asad, yes, I can see you there.
Yes.
Want to hear particularly your point about immunization. Thank you.
Yes, so I'm a doctor in the UK. I have long COVID. I have roots in India, and I've been speaking to doctors there, supporting a helpline there that is run by volunteer doctors to treat people at home. So they're delivering hospital treatment at home because there are no beds, as you know, and they're echoing some of the horrific stories that you're seeing on the TV screens. But one thing that they are consistently saying is that those who have had 2 doses of the vaccine are not becoming as sick and are not needing hospitalization. And that's sad as well in a way, because there were opportunities that India has squandered in that they had time to prepare by upskilling staff, by putting in the infrastructure, by accelerating the vaccine program, and they didn't. So what we're seeing is, in part an avoidable catastrophe. And your point about countries taking this opportunity to prepare couldn't be better made. I think there's a lot of learning there that just doesn't seem to filter through, and complacency sets in once the cases fall.
I think we are honoured to have you with us, Asad, and thank you particularly for that observation. Avoidable. Hold that onto that word. It could have been avoided. And use the time when you've got few cases to get everything prepared and test it. What we've always learned about outbreak response is you've got to rehearse, because you need to create as close as possible the conditions that actually happen when you've got something bad going on for your exercises. Otherwise, the exercises will just be useless. So I'm really glad, as I said that, and it must be very distressing hearing colleagues' words from India. This is never nice when you're doing clinical medicine, when you realize that the demand on your services far outstrips the supply side, and you feel a sort of deep sick feeling inside you, particularly when people are sick, and the distress of those who are caring for them is bad. And all of us who've encountered people who are severely ill with this disease, it's a particular distress because the patient says, I can't breathe. And it's not a case of I can't breathe because somebody is sitting on my back or something. It's I can't breathe because my lungs will not expand. They've just stopped working. And I mean, we know that because if you're running a ventilator and you're trying to get air into lungs of somebody who's got advanced COVID, the pressure you have to pump the air in with is huge, because basically the lungs just go solid. So normally we breathe in and our lungs expand beautifully and we can sing and shout. But when you've got COVID, you got to breathe. And you have to lie on your chest. It seems to be the easiest way to somehow expand your rib cage so you can get air in, but it's really hard. Anyway, Lewis, forgive me, it's your job. I know you do this all the time, but the breathing challenge has always struck me as being huge. And that's where this, just having a little bit of oxygen when somebody's got low oxygen saturation just makes such a difference. Am I right, Lewis? Just correct me if I'm wrong.
I think you're right, David. I'm actually in management. I'm not clinically trained, but I work with the clinicians all the time. And what you're saying describes what they say too.
Asad Khan, the breathing challenge seems to be still one of the greatest ones in helping people to get through.
It is indeed. I mean, this virus, the only word I can use is it is evil. And having actually, because I worked through the first and second peaks before I got COVID myself, even when they are oxygenated, having them in front of you, just gasping, is a very distressing thing to watch, and having to be, their family, their friend at the same time, because visiting wasn't allowed till quite later on in the UK's pandemic. It's taken a huge toll on the mental health of staff. So not only is there going to be long COVID to deal with, but the psychological morbidity hasn't been estimated yet, because the pandemic just keeps rearing its head. And we haven't had time to sit down and assess the damage that's been done to people.
Thank you very much indeed. Thank you for naming what is happening to people working in the health sector. I think it's, if we don't name it, we don't notice it. If we don't notice it, then we're not serving people. Claire, occupational health doctor, yourself struggling with long COVID, you seem to have come through a tunnel. I hope you're not going to go back into the tunnel. But you're thinking about long COVID when you're looking at other parts of the world. So just tell us a little bit about your own reflection.
Yeah, my own reflection is how it's no way to feel sorry for me, because I'm used to having illness my whole adult life. It's not for sympathy, and I would never normally talk about it other than to raise the profile of what's going on. This virus is, when you said about we may not have too many more old people dying here, the actual physical damage this virus is capable of causing. So yesterday I had a scope and I no longer can swallow properly, and the vocal cords are very swollen. This is 13 months on. And although I have background medical problems, that edema, that swelling aspect is what they've been seeing with COVID. 13 months on. And 13 months on, I've discovered I've got damaged veins in my head, which are from blood clots. And I didn't have any treatment, like a lot of people. But it's how I think Asad's word for the virus is evil. This virus is what's taking my mental breath away. So that's what I wanted to observe. And yes, I was one of the first ones that spoke to the WHO. Amali, my friend from medical school, and I both talked, we said this is what happens from our experience. So yes, the virus itself is scary. I don't really know what else to say other than that. Work, I'm a great believer in the power of work. We have to look after people's occupations. We have to pay them if they're, what more can I say?
Well, that's enough. You don't say any more. You have to pay people if they're ill.
Yeah. Thank you.
Virus is scary. So important to keep saying that. Virus is scary. I'm very, very grateful to you, Claire. I'd like now to go around the world. I'd like to go to Magin in Botswana. Magin, each week when you're on, we ask you to tell us what's going on. How's things changed?
Thank you, David. How are you?
Very good. Very good, myself.
Yeah, things are still the same. Numbers are increasing. And the the vaccine is still not available. So I don't even know where we're going. Everyone is worried. We don't know what's happening. No one is receiving any vaccination. So we have a sad state of the situation. We're just hoping they'll start vaccinating people before it's too late, because people keep on dying.
Thank you very much indeed, Megan. Everybody, the news from different parts of the world will not be nice. It's not good. We had the WHO check-in with the envoys was particularly disturbing today, the most disturbing that we've had yet. Megan, thank you for telling us. Stay connected. I can understand the frustration, and at present, it's not possible for me to tell you when supplies will come in, because the shortage of vaccine situation is creating real problems with advanced planning. But I've heard it in Botswana, there is anxiety. Thank you. Would anybody else like to come in from other parts of the world to talk a little bit about what you're seeing? Just probably got time for one more person if they want to. I'm glad, I want to welcome Jude from Liberia, who's new to our meetings. Very glad that you're here, Jude, from the Movement for Community-Led Development. Very, very nice that you're here. I can see you on the thing. So thank you for joining. Let me just invite somebody who I've never invited to speak on one of these before, so this person may refuse. Paul Thomas, you have been, as a general practitioner, leading a movement in London for rethinking what general practice is so that it is true community health care. And it is our belief that the kind of work that you're doing is paving way for the kind of public health function that is needed in the UK to deal with this kind of threat. Am I right, Paul? And would you like to say anything about it?
That's right, David, and thank you for asking me. This is quite difficult territory because the GP's training isn't really around public health and it's not actually really about community health. GP's training is largely about diseases. GPs largely are trained as specialists. Then you come to see a patient and their family, and you discover that actually a lot of what you got trained in isn't really appropriate to what you're doing. So we've got quite a big conceptual and cultural issue here. My belief is that GPs who hang around long enough and who listen enough to patients understand this. And actually, if we look back in history, this has always been the case. If you look at the founders of the Royal College of GPs, they were always saying that the GP is there to deal with all issues that people may need help with, not just diseases, and for the families and continuity of care and community embedded. And if you go back even to the 19th century, I think you can see that the forerunners of modern day general practitioners were seen as people who were friends and confidants and supporters of people in every life crisis they had, including sort of dying. Roll forward to today, and GPs of any quality or who've been around along really still recognize that, but there is this interim time when the training and the experience of new GPs, especially those who are not established in a long place for a long period of time, don't really understand this. And they've got there's this distinction between what they're really experiencing and what they've been trained to do. So if we are to make any real significant impact on this, we have to name the issue. And that is the understanding the training of general practitioners is not what it needs to be. GPs are fine. They're great, intelligent, committed people, but they're not trained in a way to understand complexity, multiple morbidities. Some GPs have signs saying one question at a time, one complaint at a time. Well, what the hell point is that when complaints don't come one at a time? They come in every aspect of people's lives. And then GPs are trained, or new GPs are trained, or think that they're trying to find the answer that's in the textbooks. Well, don't you know that life doesn't come in neat little answers in the textbook? It comes as a mingling of all these different things. So listening to all kinds of things, not jumping to conclusions, listening to people, helping people to move forward and try things out to make sense of it, starts being the GP's role. So GPs as sense makers is the role of GPs as they should be in the future. Well, that's too is not inside their training. So this can really, really, really be done, but we have to name the issue and we have to move forward with that issue at scale. Now, there are two possibilities that give us, I think, an opportunity to do this. Because if I was a betting man, I'd probably say, overall, I'm proposing something that's too difficult and it won't work. But there are two things that might work, and that is primary care networks, and that is coming out of COVID. Primary care networks are geographical areas of 30 to 70,000, let's say 50,000 population, inside which there are meant to be collaboration for all aspects of health and care. Now, if GPs who are expected to have an important role in this are able to work with public health and community development and universities and with voluntary groups and with arts organizations and lots of other people to really look at health in those areas and not to be expected to lead it all, but be able to support other people to do their bit in it, there's a chance for GPs at scale to understand what community health and being a community representative and advocate really means. So let's invest in primary care networks. The second is coming out of COVID. COVID has taught us that you have to have local collaboration for health, not just diagnosis of diseases and refer to somebody who's got an answer to that. But how do you help people who are dying? How do you support people who are carers? How do you help people who can't get food from the local supermarket? Well, you can do this through local collaboration. Well, you know what? I think these things could come together. Come out of COVID and you need to have places that are ready for the next pandemic. So you need to have local collaboration for vaccination and helping people who are struggling at home. Well, that could look awfully like primary care networks, and that could look awfully like a GP, a modern day GP, looking at what community health looks like.
Thank you very much, Paul.
All there.
Everybody, I knew Paul and worked with him quite some time ago. And one of the joys of this way of working is that you reconnect with people. Also here is Michael Gottfert. I just saw him. Many of you, we worked before. We're going to close this session now. We've got one thing we want to do before we finish. I hope you can stay on. I do want to acknowledge all of you. I love the way the chat comes alive when we have our conversations. I love the way that we are sharing and understanding what each other has to say. And I'll bet you that many of you hearing Dr. Paul Thomas thought, here's somebody who's saying what we all believe in, which is that community healthcare must be networked. Thank you, Paul, for your leadership and for the whole COIN program. It's absolutely beautiful. And I was so pleased to see Claire Rayner and others putting comments in the chat saying, go for it, Paul. You've got a good lot of supporters here. Come back and join us again. Over to you, Twee.
So you may have seen David and I have changed somewhat for our finale. We have our Nazeem t-shirts on. For those of you who do not know, Nazeem is an incredible artist from the Gambia. And so for our closing, I hand it over to Vicky, you do the introductions, but most importantly, it's a video clip on the theme of one of our 5 Ps is around people being the solution. So thank you so much for joining us. Over to you, Vicky and Nazeem.
Thank you very much, Twee. It was a bit of, I gave Twee a bit of a challenge to see if we could get David in a Nazeem t-shirt. So I'm absolutely delighted to see that he's doing it. Twee, so we've been working on a video. I love it, absolutely love it. We've been working on a video, which has been a real kind of whole community response. For those of you who've seen the artwork, we've had Chris Shipton involved in doing the illustrations. We've had Derek from Undivided Attention working with us on the video. We've had video footage sent in, photos from many people here. And Scott Knox, who was involved in the initial conceptualization, as well as just the ideas which have come out from this. And for some time, we've been wanting to produce a new video, which was really trying to take the focus away from the virus and looking at people as the solution. Nazeem, I don't know if you want to say anything.
Yeah. Hello, everybody. Hello, David. Hello to you and everybody else here today. Like you rightfully said, Vicky, I think we should move our attention a bit to the people instead of the virus, because it's obvious the virus is here now, but to make it work, we need people. And these are people who are risking it all. They're in the front line, they're in our communities, doing everything right, risking their lives to keep other people alive. So there's nothing we can pay these people. There's no amount of money we can pay these people. So all we can give is respect. We have to recognize these people. We have to respect them, So that's why we think this song is a very, very important one. And we really want it to go like viral. So everybody everybody need to see it. Everybody need to watch it. And Tui, nice to see you in that t-shirt. And David, you too, man. I hope we're gonna get pictures later of it.
Thank you so much, Nazeem. And with that, we'll now be sharing the video for the first time. This is the world premiere. Over to you, John, to share with us the video.
COVID is not going away anytime soon, so stay positive and respect the virus.
Keep on going, moving, shaking. Keep them positive, vibe. Keep on going, moving, shaking. Keep them positive, vibe. Respect for our elders, respect for our mothers, respect for our fathers and the frontline workers. We really mean it. Respect for the artists, respect for the dancers, respect for the singers. You guys are really amazing. We are together in this. Oh, boy. Oh, wow, 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 boy. Keep on going, moving, shaking. Keep them positive, vibe. Come on now, keep on going, moving, shaking. Keep them positive, vibe. Come on now. Respect for the doctors, respect for the nurses, respect for our leaders. You guys are COVID rockers. Really mean it, yeah. We know it's not easy, we're not saying it's easy, but please don't stop, cause if you like giving it up, no. Hey, keep on going, moving, shaking. Keep them positive, vibe. Come on now, keep on going, moving, shaking. Keep them positive, vibe. Come on now. We can all be heroes, but not just for one day. Respect the stay-homers who really care about us. Respect for the teachers who really trying to reach us. Respect the isolators that really protect us. Respect the vaccinators protecting society. Respect for the virus, but never let it rule us. Respect for the youth, the leaders of tomorrow. Respect for the youth, the leaders of tomorrow. We can all be heroes and COVID rock and rollers. We can all be heroes and COVID rock and rollers. We can all be heroes and COVID rock and rollers. Yeah, and COVID rock
Oh. Oh, it's great. We should have a lovely moment, Vicky, of Nazeem, of picking out our favorite little parts of that beautiful video that goes with such a lovely song. I want this song to really go everywhere because the words have such meaning and they're the words that we believe in. And look at the comments in the chat. You are wonderful. Where is Nazeem? I can't see him on my screen. Are you still there, Nazeem? Anyway, that was great. Wasn't it lovely, Twee?
It was fantastic. And I was watching everyone. We saw so many of you dancing, getting into it. It's a beautiful song, a beautiful video, and great to see that it brings all the different pieces we've seen over the last year together to into this video. We've got Chris Shipton, Josh's colleague from Live Illustration UK. We have all the words that we've been saying together, and it's just fantastic. So thank you, everyone. Thank you, Vicky. Thank you, Nazeem.
Yeah, we should give Nazeem the last word. Nazeem, come in. Yeah.
Yeah, David. You know, like I was saying,
Not the most brilliant internet situation, Nazeem.
You know, people are the solution, definitely. Some people who feel like they don't want to give up, you know, so we want to give them that positive spirit again, you know, with positive energy.
Thank you, Nazeem. I think you're in the Gambia, or not, or you're somewhere. Anyway, you're somewhere where the internet is loud. But your song is beautiful, and we all heard it, and we loved it, and we love it. And we will go on singing it and pushing it around. Thank you, Vicky. Thank you, Vicky, for bringing Nazeem to our life. Thank you, Nazeem, for bringing this energy. Nazeem, are you back? Have you got the bit of internet just last?
Yes, yeah.
Oh,
Yes,
yeah.
So
thank you.
All right.
Yeah, one more word. If you want to say anything else, Nazeem, because you got cut up last time. Do you want to say anything else?
I just want to say people are the solution, you know, people are the solution. And if like people want to see this video, you know, you can go to my YouTube channel and then t-shirts are available. I think it should be available. So we need to stand behind them. We need to give them that positive energy, like we appreciate them. So that's what the song is talking about, you know. And we want it to go out there. We want it to go out there, let people see it, so people can have a feeling like there is hope, you know. We can defeat this. You know, people are tired, we know, but we have to fight back. Definitely.
Thank you, everybody. Those of you who want, come back to next week, 5:30, I think it is, European time. Vicky's put Nazeem's video, the YouTube version or something, onto the chat. I must say I'm very affected, and so I'm going to stop now. I thank you all, and look forward to next week. We'll continue our long and wonderful journey together.